Okay, so other things like hereditary causes, we've kind of touched on that, but endocrine disorders, right? When we think about patients with anxiety, again, that could also be a hyperthyroid disorder, and that can cause tachycardias, bradycardias from hypothyroidism, hypoadrenal diseases. Those could lead to bradycardic rhythms. Congenital abnormalities in the heart, we can see this a lot in infants and young children that have not had the congenital repairs. There's a lot of different congenital defects. You're going to learn about those later. Hypertrophy, we should know what that term means, but that enlargement of the heart can also cause dysrhythmias. So lots of things that can cause cardiac dysrhythmias. When we think about atrial rhythms, we think about just dysrhythmias in general. We really have broad classifications. Like, is it a fast rhythm or is it a slow rhythm? And kind of within those two categories of fast and slow, we have lots of different potentials for, lots of different potentials for rhythms that could be wide or narrow or irregular or regular. And so we break down those fast and slow rhythms into more detailed categories. And then when we think about the origin, that's very important. So if I'm thinking about an atrial rhythm, I'm talking that it's going to originate from the atria. And ideally, an atrial rhythm is originating from the SA node, but the term atrial, it could be originating from any point within the atria. And like in atrial fibrillation, we have tons of little points where there is focal stimulus happening in the atria, where in a sinus rhythm, that stimulus is solely coming from that sinoatrial node. Junctional rhythms, this comes from the AV junction, so these tend to be slower and wider and lack that P wave because they're not coming from that SA node, which triggers the P wave. And then when we think about ventricular locations, these are going to be very wide rhythms, and they're going to be lacking P waves, and they can be very fast and sometimes slow, depending on the type of rhythm. And there's many different causes of ventricular dysrhythmias as well. So we're going to be diving into these throughout the course, and you're going to get very good at figuring out which one's which. Okay, so basic terminology. When we say sinus, we kind of hit this home a little bit, but this is originating from the SA node. When we say arrhythmia, that just means without rhythm. Dysrhythmia means disordered or irregular rhythm. These two terms get used almost synonymously, so you'll hear them used in different settings, and don't get confused when you hear both. Narrow complex, that's a term we use to describe when there's a QRS less than 120 milliseconds or 0.12 seconds, which remember that's 3 little boxes. Then we have SVT, which stands for supraventricular tachycardia. This is actually changing in the modern AHA guidelines. We're kind of getting rid of some of these terms that we've utilized in the past. But supraventricular tachycardia is basically meaning a fast, narrow rhythm that originates above the ventricles. And this term tends to get assigned to a specific rhythm that we treat called AV nodal tachycardias or AV nodal reentry rhythms. And those are very fast, narrow rhythms that require treatment generally in the field, either with vagal maneuvers or with medications like adenosine or calcium channel blockers or even beta blockers to help slow that rate down. And those tend to be because, again, of that accessory pathway in the AV node. But then we have AVR rhythms, with AV atrioventricular reentry, which is another type of reentry tachycardia that uses a different accessory pathway outside of the AV node. So I'll draw a little picture for you guys here. Like if I have my AV node right here, there can be this accessory loop that creates this basically ability for the tissues during their relative refractory period to be re-stimulated. So it creates this very hyper fast rate. Instead of the normal function of the AV node of slowing down that signal. It takes that signal, it gets stuck in this loop, and as part of the AV node is in that refractory period, that signal is coming back around and re-stimulating the other parts that are outside of that relative refractory, and it kind of bounces back and forth between these cells and creates this loop of hyperstimulus. And then that creates obviously lots of signals going down our bundles, right, and stimulating the ventricles. And so we get these AV nodal reentry tachycardias that are very fast and narrow. And this is what we use our adenosine for. This is what we use those vagal maneuvers for. This is what we use diltiazem or verapamil can be used to treat these rhythms, and even beta blockers in some cases are used to treat or maintain people that have frequent uses of these frequent episodes of this. And these tend to not be compensatory, right? They're not rhythms that are in response to dehydration or something like that. They can come on out of the blue. Atrioventricular reentry tachycardia now, and I have, let's say, my heart here, and I have the atria and the ventricles, and here's my AV node. If I have another pathway, an accessory pathway between the ventricles and the atria, I can get this kind of dual stimulus, and I can get this loop, essentially, that this can cause this loop-like stimulation outside of the AV node. And this can also cause narrow complex reentry tachycardias that are bypassing the AV node. And this is seen in something called WPW, which we're going to talk more about as we go on. But I just wanted to highlight the difference between those two terms right now. Okay, review of our antidysrhythmics from pharmacology. So we have, remember, smoke better, pot, California, and then M doesn't stand, I don't know. You can think of something for M. So class 1 is our first thing, and this is under the smoke. This is our sodium channel blockers. Remember, they're blocking those sodium channels. They're going to prolong that phase 4 depolarization. And lidocaine, quinidine, procainamide, these are the types there are more than this. The one we predominantly see in pre-hospital and emergency medicine is going to be lidocaine. It is widely used both as an anesthetic and as an antidysrhythmic, like lidocaine, and anything in that cane family that blocks sodium channels is also going to block those sensory nerve pathways. But when we give it intravenously for cardiovascular effects, it's blocking that phase 4 depolarization, which decreases that automaticity and hopefully decreases the risk of going into ventricular dysrhythmias. Class 2, remember beta blockers. These are all of our LOLs, atenolol, metoprolol. Remember, we have cardioselective and we have non-selective beta blockers that we treat tachydysrhythmias with. Beta blockers, have been widely used to maintain heart rates and treat things like rapid AFib and treat patients that have chronic needs for rate control. However, there is some pretty recent good evidence showing that beta blockers in patients that have any type of heart failure can actually be pretty significantly increase mortality. So we don't necessarily want to use it in those patients that have heart failure, but we do see it used in emergency medicine, right, for rate control, particularly in acute settings like tachycardias and with AFib, RVR, as well as like patients that have aortic dissections that need rate control. Class 3, potassium channel blockers. Remember, this is blocking those potassium channels in that, so it's going to prolong that relative refractory period and give us hopefully decreased ability to have that another stimulus to trigger a ventricular dysrhythmia. There also can be used in there is some evidence that it can be used in AFib as well with RVR. And so it can be used for a wide variety of things. But in our setting, we predominantly use it for wide complex rhythms. And with our most common use of this is going to be in cardiac arrest and refractory ventricular tachycardias after we've tried other treatments, right? Or stable ventricular tachycardias. So class 4, California, is going to be calcium channel blockers. And our two cardioselective that we are giving are diltiazem and verapamil. Remember, our other dihydropyridines, which is like amlodipine, those types of drugs are more targeting the vasculature, smooth muscle to treat hypertension. So again, calcium channel blockers have a lot of great use for us in those fast, narrow rhythms like rapid AFib, as well as SVT or AV nodal reentry tachycardia. Miscellaneous is going to be magnesium and adenosine. These just don't fit into any of these other categories. So this magnesium, I remember, can help basically regulate intracellular calcium and can decrease contractility, can decrease, it can also prolong the QT a bit. It can cause some, or decrease the QT interval. I'm sorry, the opposite of what I just said, not prolong it. So it can be used in any dysrhythmia where we have a prolonged QT interval that's triggered like a ventricular dysrhythmia. And we're going to talk about those in the next coming days, but that's going to be like your polymorphic VTAC or torsades. And then adenosine is that it stimulates the adenosine receptor on the AV node, and those adenosine receptors are going to temporarily block the signal going from the AV node down to the ventricles. So it causes a total disruption in cardiac conduction, but it has incredibly short half-life, so it wears off very quickly and can help reset AV nodal reentry rhythms. All right. So we're going to talk about these rhythms: sinus rhythm, sinus tachycardia, sinus bradycardia, sinus pause, sinus dysrhythmia, sick sinus syndrome. These are all of your sinoatrial nodal rhythms. Most of these rhythms are not fatal or life-threatening or require treatment, but they're dysrhythmias in themselves, or normal rhythms like our sinus rhythm. And we're going to talk about things within the sinus node that can cause dysrhythmias. Okay, so here is our normal sinus rhythm. Remember, we have a couple things. So we have a P wave, right? We have a regular R to R interval. Our QRS is less than 0.12 or 120 milliseconds. It's going to be less than 100 beats per minute and greater than 60 in our adult patients. And that's going to be a normal sinus rhythm. It's got normal rate, normal regularity. It's not wide, and we have a P wave. And remember that PR interval is less than 200 milliseconds, that the distance from that P wave to the QRS. Okay, first rhythm, sinus bradycardia. Sinus bradycardia has many causes, and it is a rhythm that meets all the criteria of a normal sinus rhythm, but is slower than 60 beats per minute. There are many causes of this, like we just said, right? And very importantly, when we see a slow rhythm, so let's break this down. We have a P wave for every QRS. We have a normal R to R interval. Our QRS is less than 0.12, but our rate is going to be less than 60 beats per minute. So if we were to do our 300 rule, so we can count that up. Take a second and figure out what the rate of this patient is using that 300 rule. So roughly between 40 and 50. It's hard to tell because it doesn't necessarily have a QRS right on the box. It's telling us 50 in the description, but you can always get used to using that counting rule to confirm. So what do we do for this rhythm? Well, it's very important that we understand in a sinus bradycardia potential causes. Commonly, it could be a normal variant, right? And so the only time we really worry about bradycardic rhythms is when we see signs of hemodynamic instability, right? Is my patient unstable? Are they pale, diaphoretic? Do they have chest pain? Are they short of breath? Are they altered? Then we may need to do something. And In the other cases, too, another thing we might worry about is if the rhythm is wide. So if this QRS was greater than 0.12, this could lead me into thinking that this could be a hyperkalemia. It could be something that's causing the slower rate. Our treatment for bradycardia, and there's a bradycardia algorithm you're going to learn and you're going to really get good at. So I'm not going to try to tell you exactly what to do yet, but our treatment is going to be, if they are unstable, we are going to go right to pacing, which is labeled here. And we're going to go over what pacing is. If they are still unstable, we can go to starting push dose epinephrine or an epinephrine drip at 2 to 10 micrograms per minute. The other thing that we can do is if they are stable or borderline and this rhythm is less than 0.12, we can utilize atropine. And atropine is a drug that is going to remove that parasympathetic stimulus at the AV node and SA node, and it's going to cause the rate to increase. And the reduced parasympathetic stimulation is really effective in rhythms that are caused by vagal or cholinergic toxicity. So drugs that cause cholinergic stimulus, or patients that are having an excess vagal stimulus from something, those tend to be the rhythms that respond very well to atropine. If the rhythm is wide, meaning greater than 0.12, like this kind of example here, that tells me that the rhythm is originating from below that AV node. So here's my AV node. So it's coming from down here, in my ventricle somewhere. And when that is occurring, atropine is only working right here at the AV node predominantly. So if the rhythm is originating below that AV node, atropine has less effect, but we still can try it. And we're going to give up 0.5 milligrams or half milligram. We can repeat that. And we usually give up to a milligram. If it's not working at a milligram, we may want to go to something else. The only time we go over a milligram in bradycardia is when we're pretty certain it's a cholinergic drug toxicity, like organophosphate poisoning, nerve agents, those types of things tend to take excessive amounts of atropine, like 20, 40, 60 milligrams. So keep that in mind as we go on. You're going to be going over some of these with Owen in class anyway, so it'll be really helpful in terms of getting